Good, good afternoon, dear participants. Today is the 102nd episodes of ECG Study Group's regular presentation, ECG Basic and Beyond. And today our guest presenter is Dr. Abdullah Al Mamun. He is continuing his previous lecture in this time. So I'd like to request Dr. Abdullah Al Mamun to start his lecture.
Assalamu alaikum, Honorable Chairperson, respected teachers, and dear learned audience. Me, Dr. Abdullah Al Mamun, welcome you all to my presentation. In my presentation, I will show 3 to 4 ECG cases. My first case regarding 45 years old female who presented to us with the history of dizziness and syncope. On examination, patient's pulse was 45 beats per minute, and other vital parameters was normal, with normal free cordial findings. Here is the 12 leads surface ECG that was recorded during admission. So we have a full here. There are several multiple choices, and I would like to ask the participant to answer this pool. Okay. Yes.
A poll for 20 seconds.
Yes.
So,
Tushar, should I describe the ECG?
before
Or
going
anybody comment?
explain your comment, and then I'd like to request Dr. Abdullah Jamil sir to put his assessment on this ECG. First, you say what you want to comment on this ECG.
So this ECG shows the rate is there is bradycardia at the rate of 45 beats per minute, and rhythm on first impression rhythm appears to irregular. Look at the rhythm strip at the initial part, that is first 4 beats in which P wave is absent, rather presence of retrograde P wave. There is presence of retrograde P wave, and QRS duration is seems to be normal, and retrograde P wave is disforming the terminal portion of the QRS complex. So initial part is junctional rhythm, and the later part of the rhythm strip there is sinus complex that is followed by the QRS complex, and after the sinus rhythm there also a junctional escape, that's 8 beat. So the ECG diagnosis sinus rhythm with junctional escape beats.
Okay. Jamil sir, do you want to comment on this? Anything further to add
No,
on?
he explained nicely.
Uh, okay. And very important thing is that we might see that if we look at AVR, the QRS is negative, but the terminal portion of QRS there is positive P, which means
Yes.
it is junctional rhythm or the rhythm the P is
That one
retrograde.
is the retrograde P wave.
Exactly. Yes, sir. That's why it is positive in AVR.
Yeah.
Forward, please.
So in this issue, atropine was given to increase the rate, and after giving atropine, rate was increased. The lower tracing is the increased rate. The lower tracing is there is tachycardia, maybe due to sinus tachycardia or junctional tachycardia. So next day, another ECG. That finding was similar to the previous one. That also sinus complex that it was interpreted with junctional escape beats. So this ECG also shows the sinus rhythm with junctional escape beats. So considering the clinical symptoms of the patient and the ECG findings, we should suspect the sick sinus syndrome in this case. So we go for the Holter monitoring, and Holter monitoring shows there is a prolonged absence of sinus activity, that is sinus pause more than 3 seconds, that is 3.9 seconds, and it was recorded during the daytime while the patient was awake. So this sinus pause correlated with the sick sinus syndrome, and investigation was done to exclude the any reversible cause like electrolyte imbalance, ischemia, or hypothyroidism, and all investigations reveals normal findings. And here is the ECG. Here is another ECG. Anybody can comment on this ECG from the panel or audience?
Is it second case?
No, sir. First case, continuation, sir.
Okay.
So you did put on pacemaker in this patient.
Yes, sir. Yes.
I'd like to request Abdullah Al Mamun, sir. Sir, the ECG shows there is.
In this
Can you-
ECG, rate
sir,
is
you have-
around 60 beats per minute. There are pacemaker spikes before each P wave in every complex, and followed by P wave and normal QRS complex, normal conduction. It's a atrial pacing and ventricular sensing.
So perhaps the best thing that can happen to a person with sick sinus syndrome is the atrial pacing with no ventricular ventricle.
আমি জয়েন করছি কিন্তু ওই যে আমাকে অপরচুনিটি দিচ্ছে
Hello.
Ji.
Ah,
Can I describe?
sure.
Zaman
Yes.
sir is Zaman
Yes,
sir is
please.
rightly said. So rate is rhythm is regular. There is pacing rhythm. Rate is 60 beats per minute. There is pacing spike before the POF followed by the pacing spike followed by POF. So there is atrial pacing, and PR is fixed. That is 20 millisecond, and QR is narrow. As PR is fixed, so this is dual chamber pacing in which atrial pacing and ventricular atrial is being paced and ventricular is sensed. And this ECG was recorded after pacemaker implantation. So I have already showed this slide in previous session. And in dual chamber pacemaker ECG, there is four things can happen. And number two is atrial pacing and ventricular sensing. In our case, or in case of sinus syndrome, this ECG pattern is observed. And the other three tracing also observed in case of dual chamber pacemaker. There is atrial double spike before POF and QRS. It is very easy to recognize. And third one is atrial system ventricular pacing. There is no spike, but POF spike followed by QRS. That is atrial ventricular pacing. And if patient is own rhythm, that is atrial system ventricular sensing. There is no spike. Only history can tells about the pacemaker. So in four patterns, PR interval is fixed, and PR interval fixed means that there is dual chamber pacemaker. So what should be the pacing mode in sick sinus syndrome? According to the guideline and according to the textbook, the default pacing option is dual chamber pacemaker, rate responsive. And if patient presented with atrial fibrillation, in case of sick sinus syndrome, a single chamber pacing ECG is preferred, that is BBI. And if patient intake AB condition, then single chamber AI is preferable.
I want to
Mamun,
Yes, sir.
Abdul, Zaman sir.
Did the Holter monitoring showed any episode of atrial fibrillation?
No, sir.
No. Okay.
There is sinus was there.
One thing to avoid confusion, some authorities reserve the sixth sinus syndrome for particular condition, that is tachycardia, bradycardia syndrome.
Yes, sir.
That is known as sixth sinus syndrome to many authorities. Its preferred term is sinus node dysfunction.
Dysfunction.
That encompasses all kind of sinus node disease,
Yes.
like sinus pause, sinus arrest, sinus node exit block,
And for
severe
example,
sinus bradycardia, sinus tachycardia, everything covers sinus node dysfunction.
sir, one thing should be kept in mind that is frequently asked in the exam. Which tachycardia is not possible in sixth sinus syndrome? There is sinus tachycardia. It is not
Yes.
sinus tachycardia that can happen in
Yes.
sixth sinus dysfunction. The tachycardia that seems to be sinus is usually not sinus tachycardia. It is anything other than sinus node, because the sinus node itself is very
Usually
visible.
those seems to be sinus tachycardia are
Basically, it's
most of
atrial
the time those are atrial
atrial
tachycardia,
tachycardia.
not
Yes, sir.
sinus node dysfunction.
Yes. 1 second, ECG, please.
Okay. So second case, 27 years old female presented to us with this ECG. Before going to the history, I'm going to create a full here before knowing the actual history of the patient.
Female.
Yes, sir. 27 years old female presented with shortness of breath and chest pain with this ECG. So what should be the possibility?
However, keep the poll open for 20 seconds.
Should I proceed?
Show the poll, result of the poll.
Result of the poll. Please show the result of the poll.
No, this is the question. Result. Kamrul.
Yes.
Somehow participants didn't go for poll.
Oh.
I'd like to request Dr. Shariful Halim to comment on the CCG. You want Dr. Shariful Halim?
Okay, yes, I'm online. Can you hear me?
Yes, yes. Please.
Thank you
carry.
for allowing me to describe this ECG. So this is a 12-lead ECG with normal taper speed and normal voltage calibration. The rhythm strip shows the rate is around 140 beats per minute. Rhythm is regular. P wave is upright in lead 2 and biphasic in lead V1. So this is most likely sinus tachycardia, as the QRS is also narrow. The PR interval is normal. The axis is normal. There is some T inversion in the anterior leads from V1 to V3. and the QRS is slightly wide, but does not cross the 120 mark. And there is no other significant findings. The QT interval is normal, and yeah, that's it. So those are my findings. So I would like to go with the option D, sinus tachycardia with anterior T wave inversion, but I'm not sure about the RBBB because uh, it does not look like the typical RBB pattern. So I would go with sinus tachy with anterior T wave inversion.
Is there any widening of the QRS?
No, sir.
So, sir, it seems that it's more
No,
of less.
it's no more than 80 milliseconds.
Yes,
Yes.
it's very narrow. So
Yeah.
that's why
So it's very narrow.
very narrow. Yes, sir.
And I disagree with the right bundle branch block that in V1 it does not show like that.
Yes, sir.
Even in V2 some RS pattern is there, but it's not typical of right bundle branch block. So sir, what do you say?
And sir, yeah, also there is ST elevation in lead V1. So it also looks like a cove pattern like Brugada. So it's also
Okay.
my differential diagnosis is Brugada syndrome. As in V1, it's a kind of like ST elevation in a cove pattern.
Okay, that's I agree with Abdullah Al Mamun sir. Rightly mentioned, it's not typical of RBB pattern, and also we have to look at the clinical history background. The little
so-
background he has put. The very young woman, and with this ECG, before moving on to the T wave inversion pattern, we have to look at the thing. Okay, please.
So the actual clinical picture is this patient presented to us with sudden onset of dyspnea and chest pain for 2 days, and he underwent a lower uterine cesarean section 5 days back. And in a private hospital, she was diagnosed as a non-STMI with cardiogenic shock. On examination, patient was hemodynamically unstable with raised JBP, and there is mild edema, and precoedema was normal. So consider the clinical picture and this ECG. What should we suspect? So if we describe the ECG, there is not presence of typical RSR pattern, but there is something RSR, I think, is present. And in lead one, there is another finding is in one NABL, there is slurring of S wave. This indicates the presence of RBB, that is incomplete RBB. And there is S1. And if we look at the lead 3, there is presence of Q and also TU inversion, that is Q3. So there is presence of S1, Q3, and T3. ECG diagnosis sinus tachycardia, maybe there is presence of incomplete RBB and there is presence of STT change, that is anterior T wave inversion, and also presence of S1, Q3, T3. So if we consider the clinical picture of the patient and considering the ECG findings, we should suspect acute pulmonary embolism in this case.
Yeah. And probably this slightly RS type, what is seen in the V1, is due to straining of the
Yes,
RB
sir.
due to pulmonary embolism.
Not
Most likely.
typical, but yes, sir.
But yeah. And if it is pulmonary embolism, the obstruction is could be managed, reduced, then this ECG change will come back to normal.
Yes, sir.
Exactly,
So
sir. Please go forward.
proceed, sir.
Yes,
So
yes, please.
So investigation was done. Troponin was elevated and elevated with the elevated D dimer, and NT-proBNP was also elevated. And this all these markers can be elevated in pulmonary embolism, other than the ICS. And ABG shows metabolic alkalosis. So chest X-ray show there is mild cardiomegaly with other parameters was normal, and echocardiography shows we cannot record the CNA view, So it is the still picture that was taken by the mobile. And dilated RB in paradoxical interventricular septum in flex view. And on the right, apical port chamber view shows RRB dilated, and there is mild tear. And with it also shows that the RB function is reduced to 9.6. 9.6 TAPC was 9.6 millimeter, and there is presence of dilated IBC, that is IBC plethora, and respiratory collapse less than 50%. 50%. So equimpression was RRB dilated, mild tear, and mild pulmonary hypertension with reduced LV systolic function. So we finally, to confirm the diagnosis, CTPA pulmonary angiogram was done. This is the gold standard test to diagnose acute pulmonary embolism. So the here shows the interpulmonary hypodensity area in the LPA, both LPA and RPA, that is left pulmonary artery and right pulmonary artery. This slide also shows the hypodensity area in the lumen of the left pulmonary artery. So final CTPA impression was thrombus with partially occlude the both right and left pulmonary arteries, and RARB also dilated. So the diagnosis was confirmed by the CTPA. We should also go for the thrombophilia screening. That was normal, and thrombin 3, protein C, protein S. This marker was normal. So we treat the patient in CCU with oxygen inhalation, IV fluid, injection noradrenaline as patient was in cardiogenic shock, and we also treated the patient with enoxaparin, and we treat the we discharge the patient with warfarin with the next follow-up.
Just before going on to the third case, I'd like to request Professor M. J. Ajam sir to say his comment regarding the management. Ajam sir, can you hear me?
No, thank you, Tushar. Regarding management, before management, I want to highlight just ECG point actually. It is only ECG findings is it is sinus tachycardia and incomplete RBB. Right, Mamun?
Yes, sir. TOAB invasion was
Yes. So in typical exam, we expect the answer of our fellows. What is the ECG findings? Once you see as in lead 1, there will dal mein kuch kala hai something, then you should look for the V1. Either it is complete or incomplete, it doesn't matter, but you look for the other RBB is there or not. In this typical clinical scenario, you may discover many things if you meticulously observe the ECG. It is categorically sinus tachycardia and incomplete RBB. Okay, fine. But if you look very carefully, nicely showed by the Dr. Mamun, S1, Q3, T3, 10% case, it is pathognomic. Once it is present, that should be give a clear idea, there might be a chance of pulmonary thromboembolism. So you should act accordingly. So anyway, this is the clinical diagnosis first of all, with exclusion of some differential diagnosis like tension pneumothorax, dissecting aortic aneurysm, like that, or acute myocardial infarction. But it is typically right now it is diagnosed as pulmonary thromboembolism. So primary target in our setting, we what usually sometimes we go for streptokinase. If Mamun,
yes, sir.
have you tried for streptokinase? Thrombolytics?
Streptokinase is indicated in this case, but is a patient is a case of 7 day of purpurium. So that was relative contraindication. So we avoid streptokinase. We go for enoxaparin, sir.
Enoxaparin, fine, good. So, and how many days you continue enoxaparin? 3 days or 5 days or?
5 days in hospital setting, 5 days. Then patient discharged with the warfarin, sir.
Okay, nicely managed. Why you don't consider this DOAC?
DOAC is actually contraindicated in case of pregnancy or the breastfeeding mother.
Diagnosis is not terminated.
Yes, sir. But she is a breastfeeding mother, so we.
Then you are considering for warfarin.
Yes, sir.
So, okay, in acute pulmonary thromboembolism, actually, first initial management is a medical emergency, so we should act accordingly. Then we should keep a long-term management. Either we should continue anticoagulant for 6 months or lifelong, as because it is not first presentation and there is no history of recurrence. So I think you should do at least follow up 6 months to 1 year. Then again, according to the findings, then we can decide actually how long we should continue the anticoagulation. So thank you. This is from my point of view. Thank you very much.
Thank you, sir. Mamun,
Yes, sir.
the one ECG. Last ECG.
Another one.
Yes.
This 65 years old male who is hypertensive and a smoker presented with us for the for routine follow-up. 1 month back, he underwent pacemaker implantation for his complete heart block that was degenerative cause. And on examination, patient was hemodynamically stable. And here is the 12 this ECG on follow-up. So can anybody comment on this?
I think it might be a bit
Difficult one.
better. It might be a difficult one. Can you please proceed? Then I'd like to request
Okay, yes.
Jamil sir to put light on it. But before that, you explain your thing in this ECG.
My thought. Okay. 12 bridge ECG shows normal standardization and calibration. The rate is about 70 beats per minute. And the rhythm is regular, that is pacing rhythm. And there is two spike. There is two spike here. One spike is atrial spike. SA stand for spike, atrial spike, and there is another spike, SV, that is ventricular spike. Look at the atrial spike. There is atrial spike, but there is no POF like this. There is no POF. Rather, POF presence before the spike. Here the POF. I mark the POF. So the morphology was regarding ventricular pacing. The morphology is LBM morphology. So there is RV pacing. As there is no spike after the POF, so there is atrial capture failure. That is called atrial capture failure, and there is also POF, but pacemaker is not recognize the own POF. So there is also presence of sensing failure. So this is the dual chamber pacing ECG in which RB is working nicely, but the atrial lead was not working, and there is presence of atrial malfunction that is evident by the atrial capture failure and sensing failure. So to find out the cause, we done routine investigations. We explored ischemia, electrolyte imbalance, and also it was normal. And we also do routine chest X-ray PAView, and this X-ray shows the dual chamber pacing system with 2 wires. Look at the RV lead. Tip of the RV lead is nicely positioned into the ventricular apex. But look at the atrial lead. It is dislocated into the upper part of the lower part of the SBC, superior vena cava. It's supposed to be here in this area. That is right atrial appendix within the cardiac. It should be present within the cardiac serial body. So chest X-ray finding is there is dislodgement of RL lead in superior vena cava. So pacemaker analysis was done to find out the cause. It shows there is elevated pacing threshold and normal impedance in RL lead, but normal parameters of pacemaker in the RB lead. So this finding is consistent with RA lead dislodgement. Here is some cause of capture failure. In case of dislodgement, there is a presence of elevated threshold and normal impedance. So what should we go for at this situation? Should we go for reposition of RA lead or program to BBI from the DDD mode, or we can let it be as it is, or we can put another RA lead? As patient was actually comes to us within the early period. Here is a pool here. Here is a pool.
I think we might skip the poll for particularly this case.
Okay. So the reposition of the RA lead is
What was the indication for putting dual chamber pacemaker?
sir, degenerative complete heart block chilo.
Complete heart block. Okay. In that case, if the party agrees, just 1 month old, easily the lead can be repositioned in the right atrium, atrial appendage. If party disagree to spend more money or for going to have operated again, then what we do VVI conversion of the DDD. And many patients,
Yes,
they just go to the village and remain like this with this. Virtually, what ECG you showed is virtually is a VVI.
yes.
No atrial benefit.
Maybe.
As
Yes.
as the X-ray clearly showed that RA lead is dislodged and gone almost up to the SVC. So there is no way it can capture the atria or any part of the thing.
So repositioning is the ideal for this patient.
So, in this case, we counsel the patient about the reposition of the RA lead, but patient party did need to go for another surgery. So we go for the second option, that is reprogramming to BY mode
VVI.
from BY mode. Here is the ECG after mode switching, showing pacing spike followed by the white QRS complex. But PR is variable, and the view in V1, this is the QRS complex is LV morphology, so this is single chamber RB pacing. So in case of lead displacement, that is early within 6 weeks and late after the 2nd weeks, and between the two leads, atrial lead is common. Dislodgement is common and is leads to pacemaker malfunction that leads to failure, capture failure, and failure to sense. And radiographically, it is divided into two types: macro displacement, that is radiographically is visible, but in case of micro displacement, there is no change in position. And management differs on following things. So this is the last slide, and here is in this slide I like to approach to a pacing ECG, as two cases was related to the pacing ECG. So first step is we should go the rhythm step, lead 1, lead 2, or any lead that can describe the spike clearly. So if pacing spike before the POF, that is atrial pacing, and if pacing spike QRS complex, that is ventricular pacing. If both atrial and pacing spike before POF and QRS, there is both ventricular and atrial pacing. If there is a spike but no QRS or no P, that is capture failure. Then we go for step 2, that is pair interval in lead 2 or any lead that describe the single or dual. If PR is fixed, that is dual chamber. If PR is variable, that is single chamber. Step 3 is view1, lead view1. We go for the lead view1 and we look at the QRS morphology. There is LV morphology, there is RB pacing. If RB morphology, LV pacing is there. In case of CRT, PLSBC and complicated case, that is RB percussion, LV pacing may be happened. So that's all about the session.
Thank you, Mamun,
Tushar
for
bhai.
the nice and crisp presentation. So I'd like to request, first of all, Dr.
Bhai,
MD, Professor.
there is another case. Should I go for
I,
this?
I think our uh, target is that we should present the ECGs full so that the discussion and the understanding will be proper. So we can
Okay,
show
sir.
many ECGs, but you have shown very nice 3 ECGs and we have discussed it. And before going on to the another ECG, which may take another 15-20 minutes or 30 minutes,
Okay.
the discussion part will not be totally over by 10:30. So I'd like
Okay.
to request Professor M.J. Ajam sir first to say his comment on these 3 ECGs and the clinical presentations and the discussion. Ajam sir, are you here? Okay. I'm saying that Dr. Naharuma Haidar Chowdhury is also present. Naharuma, can you hear me? Naharuma, can you hear me?
Yes, Tushar, I can hear you.
Okay, but there is a question that during pregnancy, not during lactation, the use of warfarin in the pulmonary embolism patient. So, can we use DOAC in case of breastfeeding mother who needs anticoagulation? Because warfarin has a lot of interactions and maintenance of prothrombin INR, which is very difficult sometimes in clinical practice. Can we give uh, novel anticoagulant?
Um, Tushar, if I truly say that I have no experience on that because I don't manage this kind of patient, really.
Hello. Namaste.
So it's nice. Jamil sir, Abdullah Al Jamil sir, are you, are you here with us?
তুষার আমাকে 2 মিনিট সময় দেন, একটু ইমার্জেন্সি কল আসছে শিশু থেকে।
Okay, okay, okay. So the most important thing, the Mamun showed that the clinical scenario that guide us about not only the ECG diagnosis, we should put more focus on the clinical scenario. Then the ECG diagnosis becomes much more easier or rational. Just only seeing a patient with sinus tachycardia, and if we jump on to diagnose pulmonary embolism, only basis of S1Q3T3 may overdiagnose pulmonary embolism and overtreatment. So we have to think the patient as a whole, the clinical scenario, investigation, then we can only pinpoint the diagnosis and manage the patient properly. Uh,
সরি
Ajam
তুষার।
sir, Abdullah Jamal sir, are you free now?
হ্যাঁ তুষার, হ্যাঁ বলো, হ্যাঁ শুনতেছিলাম।
হ্যাঁ স্যার, আমি বলছিলাম আমরা শেষ পর্যায়ে আমি প্রথমে আপনার কাছ থেকে এই প্রেজেন্টেশন সম্পর্কে মতামত চাই, তারপরে আব্দুল্লাহ জামিল স্যার এই প্রেজেন্টেশন সম্পর্কে বলে আমরা আজকের মতো শেষ করব। প্রথমে আমি আজম স্যারের কাছ থেকে শুনতে চাই।
আচ্ছা, তো থ্যাংক ইউ ভেরি মাচ। অ্যাকচুয়ালি ECG interactive session really fruitful for not only the fellows, as well as we also learn a lot of things from our brilliant upcoming emerging leaders. So we must appreciate them, number one. Number two, in our clinical practice, our clinical teachings to our fellows is whatever the presentation, we should critically evaluate the patient's clinical presentation first. These presentation gives a clue for investigation, and this is normal strategic approach of any patient management. History should come first. 80% case we can diagnose by history. Only 9% case we can diagnose by examination, and 9% case we can diagnose by investigations. But in clinical cardiology practice, it is also applicable in that manner. But in that particular case, actually, every case nicely presented and nicely depicted the history and clinical intervention as well as investigation done properly. So, what I just remember, you are talking about this second case, like most likely, it is pulmonary thromboembolism. So, it is actually clinical diagnosis. On the top of clinical presentation, some investigation gives us a clue, so we can proceed accordingly. Finally, we can reach our final diagnosis. Once we reach a diagnosis, then we can manage this patient nicely, otherwise we may lose this patient. Overall, my impression, today's presentation really excellent. We should appreciate. And one thing, as you mentioned, Tushar, S1, Q3, T3, it sometimes may be overdiagnosis. It is not actually overdiagnosis. It gives a thought-provoking idea what next actually. It doesn't mean S1, Q3, T3 means pulmonary thromboembolism. It gives a provocation. You have to confirm your diagnosis with confidence. So I
Exactly.
think, uh,
Exactly,
I-
sir. That is only S1 QC TC and sinus tachycardia দেখি কেউ যদি pulmonary thromboembolism থেকে যায়, that will be wrong. It is
yes,
clinical context very important,
right,
not the
right, right.
ECG.
It is only just give you just extra confidence. Yes, it might be. So you should go for confirmed diagnosis. If you to see the presentation and hypoxemia, if you go for at least hypoxemia, clinically with ECG, these all favor for pulmonary thromboembolism. But you until and unless even you can go for bedside echo, if vigorous movement of the RB outflow tract, then you may give us so conclusion, draw conclusion. Yes, it might be. Then you go for CTP, pulmonary angiogram. Then you go for the diagnosis, confirmed diagnosis.
One
So
thing,
anyway,
Azam,
sir,
I'm interrupting a little bit. That
sure, sure.
S1 QT3 syndrome is not always present in pulmonary embolism, even massive pulmonary embolism.
No,
So
sir, it is only 5 to 10% case it can be
yeah,
found.
yeah.
But
So
if you found it,
if anyone does not get this in ECG, one cannot exclude pulmonary embolism. The clinical scenario is the most important thing.
definitely, definitely.
Yeah.
So, sir, so I think I should conclude my impression on that presentation, and we hope in coming future more elegant talk will be ready to hear our future leaders. Thank you very much. And rest of the thing will be covered by Professor Abdullah Al Jamil sir. And he
Jamil,
also teach us actually in taught us in our fellowship program. S1 Q2 T3 is a pathognomic in case of pulmonary thromboembolism. So I must give a special thanks to Dr. Abdul Al Jamil sir. Thank you very much, sir.
Jamil sir,
Yeah.
Jamil sir, please share your thoughts and conclude the session.
First, I thank Mamun for presenting 3 nice cases with very good ECG description and interpretation, and also the management of these 3 patients. Um, the previous session also he presented very nice cases, so I should request him to continue and keep it up. And all the 3 cases were excellent and managed nicely. Nothing to say more about these things. So, what I had other thoughts I've already discussed. So, thank you all, everybody, for participating, the participants and as well as the faculties. Thank you very much.
Thank you, sir.
Tushar.
Thank you, sir. And next month is the month of Ramadan. So our ECG study group presentation will be in a halt for the month of Ramadan. After Eid al-Fitr, we will start the program again. Thank you all for participating in
So
this program.
from second week of April,
Hopefully, sir,
second Sunday.
আমরা সেকেন্ড সানডেতে ইনশাল্লাহ করতে পারবো, কারণ ফার্স্ট সানডেতে তো আমাদের ঈদের পরপরই পড়বে ফার্স্ট সানডে। আমরা সেকেন্ড সানডেতে হোপফুলি উইল স্টার্ট ইট এগেইন। এবং আমাদের পার্টিসিপেন্টকে আবারও ধন্যবাদ জানাই, এবং একই সাথে আমি ধন্যবাদ জানাই বেক্সিমকো ফার্মাসিউটিক্যালসকে, দোজ হু আর গিভিং আস দ্য টেকনিক্যাল সাপোর্ট। Thank you all. Thank you, Dr. Mamun, and thank you all the participants.
Thank you.
Thank you. Allah Hafiz. Good night.